Joel is doing. Emma, I'll hand over the mic to you.
Lovely, thank you. Thanks everybody for logging on. It's really good to see some familiar names actually, and some familiar faces in parts. I'll introduce Joel Murray. He's our current PFET fellow for transplant at the Royal Melbourne. And we've taken the opportunity to talk a little bit about donation because it does cover the breadth of us in terms of particularly abdominal donor surgeons. And we really are at the interface of donation and transplant, so people who participate in both domains. And as surgeons, we have an absolute crucial role in the outcomes for multiple patients. I mean, clearly the donor outcome is determined, but we have or can potentially influence the outcome for multiple patients in our donation procedure. So we were going to talk about non-utilisation of kidneys in Australia and recent trends and present some data around that. And then hopefully that will open up a broader discussion about how we can make some improvements in the current trends that we see. So I'll hand over to Joel, and I'll keep an eye on the chat. And at various points, we may stop for comments. Thank you, Joel.
Great. Thanks, Emma. I'll just share my screen. So hopefully everyone can see that. Yeah, so I'm Joel, one of the trainees at Royal Melbourne. My first experience with transplant started when I was a resident of the Alfred and was a cardiothoracic resident, and got the call up by one of the fellows there about 2 a.m. in the morning. Said, do you want to go to Sydney and pick up some lungs and a heart there? And being a sort of a third-year doctor, thought that was awesome. So got on the taxi, got on the Learjet, flew out to Sydney, got the police escort through there, which was awesome as well. And we get there not knowing what to do, take the esky in and all the other familiar things. And we get to the point where we realized that there was a lesion on the lungs, and we couldn't actually end up taking the lungs, and seeing both sides of that. And it kind of didn't twig on me at the time, like it doesn't when you're a junior doctor. You don't really kind of understand the ramifications of things. But down the track and seeing those processes now, and seeing it this year and over my time, seeing the effects of actually what that means for the donor surgeon and accepting the organs, and what that means for the patients, for the people donating and the families donating, and also for the patients hoping to accept those organs. It's pretty impactful, and so it has a lot of impact whether we accept organs or not, and how we go about that process. So that's what we wanted to look at today. So yeah, the title is yes, yep, yeah, nah, and it's a little cheeky, but it just captures a grey zone of what it's like in the face of transplant decision making sometimes. So because we kind of evaluate kidneys in the offer and evaluate in the process, and then often we make make judgments on whether or not they're good enough to transplant and who they're good enough to transplant in. And unfortunately, the answer sometimes is increasingly nah. So we'll cover first the scope of the problems, how many kidneys are being discarded and why, and then we'll look at national and international trends and what the data shows in Australia. We'll look at a bit of Korea and UK and the US. And then we'll move on to explore why kidneys are not being used, including back table and biopsy decisions. And then we'll just look at some of the real world examples that we've had through RMH. And then we'll go on to discuss just a bit of the solutions and how we might increase utilisation, and also talk about a bit about the sort of the hot topic of machine perfusion as well, hypo and normothermic. So if we look at the trend of non-utilisation rates in Australia, we can see that there's a significant increase in non-utilisation since 2010, moving up. And we see that in 2024, we've got an increase of approximately about 12% of non-utilisation of the kidneys retrieved. If we look over at what the rates were like of non-utilisation in the orange here compared to what we've used in the green, look between 89 and 2004, we can see that it was about a 7 to 8% over that period of time. However, if we look at the bottom data here, we can see in 2024, there's been a significant increase at about 15% in Victoria and about 12 to 13% in New South Wales of non-utilisation of kidneys. Significantly different to Queensland and also WA as well. Sorry. So we can look at a bit further internationally and start looking at how this relates to some really good data through South Korea as well, where we see the proportion of discarded organs sits at about sort of 1%, 1.5% here. And this is kind of the gold standard that we'd love to get to. And so we thought we'd look deeper into what we're doing and ultimately how we can get to this point. If we move on to the United Kingdom, despite being well coordinated and central through the NHS, around 18% of kidneys are still not transplanted. This highlights that even in high-performing systems with clear protocols and significant portion of kidneys are lost. In many cases, this reflects either conservative clinical judgment or mismatches between donor characteristics and available recipients as well. And this is nothing compared to the US, which presents perhaps the most sobering figures, where in 2010, they discarded approximately 2,500 kidneys. And by 2023, this number had increased to more than 8,500. It's more than triple the original figure. So during this time, donor numbers increased by 57% and transplants had increased by 40%, but kidney discard rates had increased to over 220%. And if we look at reasons for non-utilisation, we can see that it's generally related to either DCD, a history of hypertension, and history of diabetes. These were the key main things for non-use of the organs. However, if we don't adjust for these donor factors, the odds ratio for non-use in 2023 was 1.12 compared to both 2010 and 2018. It's a great little slide that talks about the effect or the weekend effect of procurement and discard rates in the United States, and it shows that if it generally relates to the weekend, so we call this the weekend factor, where discard rates were significantly increased if the procurement happened on a Friday or a Saturday. So within Australia, once again, we can see that there is this increasing effect of non-utilisation. And this doesn't seem to be related to age or to donor age. As you can see here, they're generally equal within the age groups along the years from 2005 to 2024. So we're not necessarily taking older or more comorbid patients. So I just wanted to look back at, sorry, just give me 1 second. So yeah, this looked at so Matt Sypek, one of the nephrologists at Royal Melbourne, looked at what the increased rates of deceased donor kidney non-utilisation in Australia was, and he looked at his data from 2000 ANZ data registry from 2014 to 2021, and he looked at all deceased donor kidneys offered for transplant within Australia. The key findings were the increased rate of deceased donor kidney non-utilisation over this period of time, with the overall non-utilisation rate about 18%, with the risk factors for discard of kidneys, age greater than 65, whether they were DCD donors, and once again, history of hypertension and diabetes, terminal creatinine and kidney biopsy performed at the time of retrieval. And there was also some regional variation in discard rates as well. Look, the implications of this and the recommendation of these studies were that many kidneys discarded were due to perceived poor quality or logistics, despite potential for use. The use of a biopsy as a marker of uncertainty and often frequently led to rejection. And this emphasised the need for a national standardisation in biopsy interpretation, better utilisation of high-risk kidneys, system-level audits to reduce variation in practice, implement centralised and digital biopsy review, improve backtable training and perfusion assessment, the use of machine perfusion to better evaluate marginal organs, foster a culture shift from risk tolerance and clinical confidence, and develop donor risk calculations and match algorithms. We also, the study was also looked at through the Sydney group with Cutting et al. We looked at all deceased donors in Australia from 2014 to 2021, which is the period here we can see in circle, where there was an increase of non-utilisation of donors from around 6 to 7% to over 10% within that period of time. It found that the indications for non-utilisation were older age, once again DCD. There was also socioeconomic, showed a disadvantage as well, and then a cause of death with non-neurological conditions. So when they looked at the reason for discarding the organs, one of the main keys was poor perfusion, and this was related to DCD as well. There was also, one of the keys was either vascular injury, vascular malformation, or vascular abnormalities, and also scarring or cysts. One of the ways in which we could easily improve this was trauma to the organ that had happened at the time of retrieval. Was either surgical damage, retrieval injury, treatment injury. These were the main factors. And there was 42 that were deemed not suitable for recipients. And this is a system issue that we didn't manage to get right at this time, where we couldn't find a suitable recipient for the organ. So once again, we looked at the data from 2024, as you can see in here, where we've got a non-utilisation rate of about 12%. If you look at this graph down the bottom, we talked about, see some differences in New South Wales and Victoria compared to specifically Queensland and WA and South Australia. And one of the thoughts that we had was whether or not this is related to the multi-centre approach that we have in Victoria and New South Wales, where compared to the single centre uses of Queensland and WA of retrieval and transplant team. So the trends in kidney non-utilisation rates in Australia show that this is what we've seen over the last 4 years, where intraoperative assessment, we've seen 46 discarded within 2024, and then 42 discarded at the actual transplant unit or the receiving unit. We don't have too much data in terms of what the other, and this is one of the areas that we think we could probably improve on, is this documentation and reporting of where we, of why we haven't taken the organ and what are the decisions that have led to that as well. It's just a way of auditing that process and a way of trying to improve that process as well.
Joel, if you want to stop there for a second, I'll open the floor up to any comments in regards to the data you've presented. There's a few particular things that we can certainly draw out.
Yep.
You're mentioning of the single-centred approaches in some states where a transplant unit and surgeons within the transplant unit perform most of the donations is an interesting one, having worked at multi-centres. So you may have, for instance, in Victoria, may have a donation service which has surgeons from multiple hospitals who then retrieve kidneys for 6 or 7 hospitals, compared to, as you said, Queensland, for instance, that operates out of one unit, the PA. But there are certainly very significant trends in the graphs that you've presented. Some of them do relate to donor characteristics. Others, though, cannot be completely explained by donor characteristics, as you've intimated, particularly with the US data, where changes in the donor pool don't necessarily completely account for the increased non-utilisation rate. Has anybody noticed any changes in their practice in the last decade or so? Any personal experiences with increasing non-utilisation of organs? Santosh, got your hand there?
Yeah, thanks, Emma. Yes, I think DCD came here, or we started DCD in South Australia at the Queen Elizabeth in 2008. And then the DCD numbers were hardly about 5%, and in no time it became 20%. And now with certain months, it is half our 50% of our transplants are DCDs. So therefore, and then the practice of earlier waiting that 1 hour on the DCD for the heart to stop, and now that getting more prolonged, and the actual functional warm ischemia in terms of hypotension less than 50 and those sort of the factors, I'm not entirely sure how much it is playing. And we do find kidneys which are not 4x4 perfused. They are usually 3x4, or still we find kidneys coming through. Just the other day we had kidney came through with a lot of blood inside. It was not totally blanched, and so on and so forth. The other question I had, Joel, was that in these stats that you showed, are there pediatric donors, or it is only adult donors that we are talking of? Because the reason why I'm asking that is because the pediatric world, the rate of discard is much higher in terms of like almost 40%. So a lot of the American data that comes through is usually has pediatric stuff as well in it. That's why I asked.
Okay.
Yeah, I think the data that we have is raw data from the ANZOD website for 2024, so it includes all pediatric donors as well. Yeah. Certainly, Amma. Oh, nice to see you, Amma. Well, not see you as it may see.
Put my face up.
There you go.
Hi. I just got a quick comment / question. I think it's a big and important difference to say, when it's non-utilization versus something that's retrieved and discarded, because they're very different topics. Like non-utilization could mean that these were offered out and no one accepted them for whatever reason. That's usually going to be those, older patients with diabetes or hypertension. And, to be honest, a lot of them could be very much rubbish, and there's little you can do to reverse that. But then there's a difference between that and organs that are retrieved and then discarded for some other reason. For example, poor perfusion. So those are sort of two different topics and two different areas that need to be looked at quite differently. And I think, obviously I haven't been around as long as some of the other people here, but just in the year I've come back as a consultant, I've noticed we've been getting a lot of, offers of very old DCD organs, which seems to be quite different to the even few years ago when I was, registrar or whatever. So there's something that's changed there.
Yeah.
I think I would agree with you. And Joel's just flick through back to that slide from the data that was from 20, what was it, 20?
8.
Yeah. So in that 4 years ago, period 4 years ago. And there was only a few, like a handful of the kidneys that were not utilised that were actually from lack of recipient compared to other reasons. And trauma to the organ stood out to us as something that was, something that could be avoided. So, potential yield there, in addition to poor perfusion and DCD. But notwithstanding, I agree with you, Arma. There seems to have been a bit of a change in quality, but also a bit of a, for us, I suppose, in the last 10 years that I have been around, we've become a bit more risk averse and potentially accepting organs for patients that we're then not happy to transplant into that particular recipient, but then have run out of time to be able to offer it on. And for people to reasonably accept it if it has a ischemic time of 10, 12 hours. So I think there may be issues around not having a recipient full stop at the time of retrieval, but there's certainly also issues around not declining an organ for a particular patient and then not having enough time to be able to reoffer it to a suitable recipient. that's something that we've experienced, I suppose, in the last few years as well.
Yeah, I was wondering whether there's and I was going to talk a little bit about this down the track, but whether there's a role of a discussion between the the understanding of what the organ and the quality of the organ, and what the patient is understanding of what they want out of the organ as well. And if it is, if there's a high risk of failure, or as in it would not last, we're looking at a couple of years rather than looking at 5 to 10 years for this kind of organ, whether the patient is looking for that to get off dialysis for a couple of years, just in terms of being able to travel. Or there's an interesting talk by one of the transplant physicians at TSA this year, which talked about the geriatric recipient, and looked at their expectations for what they wanted out of the transplant, and often it was just a couple of years, just so that they could travel again. And they weren't looking at 5-10 years, but they were more looking at that 3 to 5 year of just being able to have that freedom in their later years as well. So whether there's a role of that understanding with the patients and with the recipients, and whether they would be willing to accept those organs based on that.
Santosh.
Yeah, thanks, Joe. I don't entirely buy that argument by the physicians. And the reason being, see, we are actually retrieving from extremely older donors with multiple comorbidities, and putting in this organ into an equally old patient who's got crappy vessels to play around with, and having more complications in the post-op period. It's all good when we are able to get the patient through the transplant, and he might get that couple of years of good life after that. But equally important is that it may not happen like that. And in the same breath, I would also say that there is also a push by the nephrologists to put in dual transplants in the same breath, saying that, hey, let's now give 2 kidneys to one person. Same argument. But the fact is that it is double the problem and more the common. So I don't entirely buy this argument, but then of course the debate goes on.
Yeah, it was for me, obviously being as a trainee and new to this, it was interesting because we listening to that talk, and fresh in my mind was a couple of transplants where there was a marginal donor with a marginal recipient, and significant impact to the patient's quality of life through the surgical procedure and post-operative recovery as well, with significant delayed graft function as well. So watching having those patients fresh in your mind, made me think similar as well. It's okay to have this push and look for that, but often the reality and what we're facing, the patient on the table and in their post-operative period, is they've got some extreme risks that they're taking for that.
Thank you. Peter, you had your hand up next.
Oh yeah, I was just gonna say something similar to Santosh. I mean, I'm currently a PA now, but we have something called a over 60s list, which basically is activated when there's sort of a marginal donor who we expect, the organ quality to be not to last more than 10 years, for example. And I feel like Santosh is in the same boat, but like we get this marginal donor and to a marginal recipient, particularly who will not tolerate any complications very well, and an elderly patient. So I think it's getting trickier, and we're definitely getting more DCDs and more elderly donors referred to us at the beginning, which certainly has been declined quite a lot. And I think that's what part of the higher non-utilization rate is, certainly as Arma has stated. And I think there is relatively low, I'm just going back to that multi-center argument as well. And I think that actually does help, because we often get involved with the donor, but we also recipient surgeon as well. So there's a very close discussion with the Donate Life coordinators from the very get-go and the nephrologists. So it's much easier for us to coordinate utilization of the kidneys if we do accept it.
Yeah, I would agree with you, Peter. It does seem to be when you have that single centre approach, you may have more opportunity to find an appropriate recipient for the perceived quality of the organ before it's actually retrieved, which reduces that ischemic time and sets patient expectations, you know, from the start as well. And Tana, you next had your hand up.
Oh, thanks. I agree with what has been saying. Like, definitely in New South Wales, we've definitely had a lot more extended criteria DCD donors, and I suspect that, you know, if you have a donor that's in their 70s and you find that the perfusion is not so great, people are much less, they're more risk averse and don't want to accept organs that they would have otherwise if it was a 50-year-old donor. And the other thing is, like, in New South Wales, obviously there are KPIs with Donate Life in terms of performing retrievals. And I have noticed that there's a lot of, there have been much more borderline donors that go ahead without the kidneys being allocated. And then eventually they basically just don't get taken by a unit because they've gone through the whole list and no one's accepted the kidneys. And the other thing is obviously the renal physicians that accept particular donors are from different units throughout New South Wales. So there's not that, I don't know what the correct word is, but the unit's not inclined to take the organs per se. You know, it's not all from one unit, like in Queensland, where often the nephrologists are going to be associated with the unit that's going to be taking the kidneys. So I suspect that they have a much lax criteria to accept potential donors.
Yeah, I agree with you, Tana. We seem to have that a similar thing in Victoria where you'll have a nephrologist who has a fairly low chance of having to accept that kidney for one of their recipients, but you know, that kidney might go on to other centres and you know, be a challenge. The other things to say in that process is the surgeons are fairly rarely involved in the process of or donor suitability at that early stage, and we have had on occasion, or going out to retrievals on occasion, we then have the opportunity to look at CT scans and pick up issues with kidneys or pick up multiple vessels that are, you know, with heavy atherosclerosis, that type of thing, where you know, it bears out in the donor that has then gone through that process. And I think in this whole issue of non-utilisation, you can't underestimate, I suppose, that the potential. So there's the economic cost, but also the cost to families, potentially, particularly with DCD donations. It's quite a process for families and donor families to go through to then have no result or no positive outcome from it. And I suppose if these kind of numbers, these non-utilisation numbers, were to be made very public, there might be a bit of an issue with public perception around that. And it, you know, from a PR perspective, that would be fantastic for Donate Life. Oh, sorry, Santosh, you have your hand up, and then we'll move on after that.
Yeah, thank you, Emma. Just when Tina mentioned about the age, 70 years, and you sort of partly alluded to the CT scan, I was just keen on knowing how often are we doing CT scans for all these patients, the older donors, or for instance, any donor, for instance? Because my corollary is that if I go to buy a second-hand car, it's like buying the car, and then the deal is that I just have to put petrol and then drive. And if it works, great. If it doesn't work, you know, I have to start fixing problems. So I sometimes wonder, because we struggle with getting CT scans, imaging for our patients from the ICU, because it's always a contest with logistics, at least for the abdominal organs, not so much for the heart lung, but for the abdominal organs, it's always a contention. So I wonder whether the rest of you all face the same thing, or you all get scans for all the donors that come through.
I can tell you in Queensland, if the liver is in, I can say more than 90% people get a CT scan. If it's just kidney only, probably I'll say even then more than 50%. So it's actually quite common for our unit to get a CT scan, and it's actually initiated often by the nephrologist, funnily enough, and they always call us to have a look at the CT scan.
From my perspective in Victoria, we don't specifically get renal imaging for kidney-only donors. The CT scans that we have access to are either done for the purpose of their liver donation or have been an incidental CT on patient presentation or as part of their investigations on initial presentation. So the only objective information often that we have to work on is creatinine and oliguria, or urine output rather. I'd be a fairly strong advocate for patients who have a KDPR greater than 90 to have some imaging before they go to retrieval. And I think that would perhaps reduce, as I said, huge resources associated with retrieving organs that do not going to be utilised, but perhaps you could have predicted that, with simple imaging. Joel, perhaps we'll move on to the rest of the slides that we have.
Yeah. So we thought we'd just go through, obviously, a bit of back table assessment that we've come across at Royal Melbourne, and you're looking at generally perfusion quality, the macroscopically, looking at the kidneys as well, and then looking at the anatomy of the kidney too. So we just thought we'd go through a few cases and just see what people think about these ones, and feel free to chime in with them. So this was from a young person who we were offered this kidney, and this was related to died from significant trauma, had 2 long bone injuries from a motor vehicle accident, and ended up having dying from a fat embolism in there. And we had this kidney where we showed area of poor perfusion and necrosis down in the lower inferior pole there, and we're asked whether or not we would put this in. Has anyone got any thoughts on this, or any experience with anything like this, with a fat embolism, patient passing away from a fat embolism? So it looks to us that it was just sort of initially thought it was just kind of focal within that lower pole. However, we went on. Santosh, did you have your hand up?
Yeah, we had, we do find these things often on biopsies, but usually as long as the perfusion is good, these kidneys work, is the feeling I have. Yeah, and it's worked for us.
What about you, Marcos? Did you have your hand up?
Yeah, I did.
Yeah.
So what you see on the kidney here, it's a marker of systemic emboli.
Yeah.
So it's not just on that pole of, so for livers, I don't know how you do for kidneys, but if we see something like this at the perfusion of a liver, we'll be pretty concerned, because you can't see what actually is happening in the microvasculature of this liver. So the liver is probably what be utilized. I don't know what the kidneys, but
Yeah, as a bit of additional background for this particular patient, he had an AKI that evolved. He was GCS 15 when he came in with his trauma, but had a seizure in ED and then went to ICU and was brain dead beyond that. And the presumptive diagnosis was fat emboli. And we ended up getting a biopsy before we saw the perfusion of the kidney, but there were very few case reports that actually allowed us to get an indication about what the outcome may be. The only 2 case reports we found actually had poor outcomes. But this is not his biopsy. His biopsy was much worse than that. It had lipid throughout all glomeruli that were causing congestion. So not only did he have what looked like segmental emboli, but all glomeruli were full. So one kidney went interstate and was used, and the other kidney came to Royal Melbourne and was not used. But it's an interesting kind of case of, a fairly young kidney, which if weren't quite aware of the underlying pathology beyond what you see in terms of the, potential segmental emboli, potentially putting that in a patient, could have been, or likely to result in fairly poor function.
Yeah, so it was a systemic process that for this patient, as you pointed out, Marcos. throughout, or microemboli throughout the kidney as well, although it looks like it's perfused and the rest had these microemboli.
Sorry, Emma. So what happened to contralateral kidney, which was transplanted in the interstates? Do you know any?
Yeah, no, we don't have any information in regards to that. So this is only a few months ago, but yeah, the kidney was, as I said, was transplanted interstate, young donor, fairly well matched for that particular recipient. The team there weren't concerned about the history, and our biopsy come back 12 hours later because it was a rapid retrieval, and it was done overnight. So it, I've lost the donor number actually, but it would be interesting. I know the hospital would be interesting to find out what actually happened. But all the case reports in the literature in regards to systemic fat emboli had very poor outcomes in the recipients, as
Yeah,
in not kidney non-function essentially.
that's true, because I know, when you got even we call cholesterol embolization, they won't work well. So that's, if you got a fat embolization, even worse, I guess. Yeah. That's very good case. Thank you.
Next one, we received this organ where referred with the information showing that there was poor perfusion in specifically the lower pole, and once defatting and doing the back table, we found that there was a missed inferior pole artery to here that just hadn't been perfused through there as well.
So this kidney was probably about 12 hours down the track, and the inferior pole artery was very short, and it would have been a difficult transplant. So very short and very small, and when attempted to reperfuse, to flush fluid through, it didn't clear. I suppose we're really risk averse in terms of lower polar arteries, segmental lower polar perfusion defects, and lower polar arteries like this applying the ureter. And we're generally, when we see poor perfusion lower pole, would be reluctant to transplant these kidneys. Is that everybody else's experience in terms of lower pole poor perfusion, or do people have a bit more of a not a laxer approach, but a more relaxed approach in regards to that?
Go for it, Santosh.
No, I agree, because often the ureteric blood supply, we think it comes from that lower pole, but in this particular patient, obviously it's not, that particular area has not been perfused for over 12 hours. So I would be, I would agree with you.
Yeah, I suppose it also just goes to show that on the back table, we need to be really quite careful in regards to identifying the arteries. And then if we do see areas that are non-perfused, and flushing them out as we can on the back table, because those they're very hard to flush out many hours down the track.
We'll move on to this one. This is what we saw after perfusion. Obviously, you can see some petechial hemorrhage throughout the kidney there as well. Does anyone have any thoughts on how they would progress looking at this kidney, and what their process would be to decide whether they would implant this kidney or not?
Ashwini? Hello, Ashwini.
Hi, Emma. How are you?
Good, thank you.
Look, these sort of kidneys, I guess I've seen before in both my training, and it's interesting because in different units they would be managed differently. I've seen them I've put in some myself, and they've had graft function or immediate function, delayed graft function or immediate function, and I've also seen some where we've discarded when it was way more extensive than this. So I don't know. I think just based on what I've seen over the last few years, I may be inclined to use it, but I'm not 100% sure. What's everybody else's thoughts on this?
Yeah, go for it, Santosh.
I'm not sure. I'm just seeing two pictures. The second, on the one on the right, seems much better, as in like perfusion wise. But all those ecchymotic things usually I see in patients in ICU who've got septic foci and stuff like that. So it's very common in patients coming from the ICUs. and these kidneys do well unless there is systemically there is a blood culture which is some sinister bacteria. But otherwise, we are happy to use it because with the current antibiotics we have, it kills a lot of stuff. So,
Yeah.
Rulan.
I would take a biopsy, like a paraffin embedded biopsy, and machine perfuse it and see if the rate of the perfusion increased over time. Paraffin biopsy often takes a few hours to come back, about 7 or so. And if there's no chronic disease in the kidney and the rate of perfusion increased on the hump, you cannot use it.
So on the hump.
Yeah.
So yeah, so resistance, it wasn't high resistance, yeah, and rate of perfusion increased. How about Taina?
Yeah, I guess for us, if that was a DCD kidney, we have the benefit of putting it on the machine to see how it looks, and that'll give us a good idea of whether it be something that's usable.
Do you expect the look to change on the machine, or it's more just related to your perfusion?
So we perfuse it with blood, so we can. It's pretty obvious.
Normothermic, sorry. Yeah.
Yeah.
Yeah. So I think you see a variety of different approaches, and for those who do have the benefit of machine perfusion, and particularly normothermic machine perfusion, that it's fantastic to be able to assess quality from that side of things. And from the point of view of hypothermic machine perfusion, it buys you some time and it gives you that kind of objective parameter in regards to vascular resistance and flow rates, etc. But it does more comfortably buy the time from the biopsy point of view, and or potentially getting an alternative recipient if your potential recipient was fairly young and there are other factors within the donor beyond this type of petechial type hemorrhages within the kidney that might make you a bit more uncomfortable. So I mean, those are clear clinical benefits for the machines. For those people who don't have the benefit of the machine, we're back to the assessment based on donor factors in addition to the perfusion characteristics. So both of these kidneys were used, so the left and the right one was similar, went off to different hospitals and went off without biopsies actually. So it just goes to show different, I would have biopsied these to get a bit of an indication, but I believe this donor had a low flow state for a period of time, and maybe that might be the reason. Next one, Joel.
Yeah, this is just a kidney that we received with a biopsy taken.
Yeah, so this is a kidney from a blood group B donor that was well matched to our recipient, but the biopsy was about 1.5 centimeters deep, and it may not be appreciable on the photos, but you can see differences in the parenchyma, and there was a tiny through defect which looked like it may be intercalyx. So we were very reluctant and garnered lots of opinions, but eventually passed this kidney back on to Donate Life. And we're using this particular example to stress that we don't have a uniform biopsy practice across Australia. Some centres use true cut biopsies or needle biopsies, other centres use wedge biopsies, and nephrologists have to be really quite careful in determining when they will use a biopsy because it's not without issue, as you can see. But biopsies traditionally have a fairly poor, I suppose, concordance rate, particularly when it comes to things like glomerulosclerosis for kidneys. And you want to be pretty confident that you're subjecting the kidney to some trauma for a reason. This kidney perfused well. It was from a donor in their 50s, and I think there was a slight AKI, which is why it was done. Santosh.
Yeah, I wonder why the biopsy was done, because this biopsy, it looks like it's been done for some sort of a lesion, a suspicious lesion. Now the other thing that to rule out pelvic ileal breach, probably like what I do for, say, if I deroof a cyst or something like that, is put an infant feeding down the ureter and push fluid through it. If you see stuff coming through it, it has breached the renal pelvis. Otherwise, it should be quite intact. A few, interrupted absorbent sutures should do the trick.
Okay. Interesting. Move on to the next one. This was one of the first kidneys we got from a COVID donor. It's a very odd-looking kidney, and you can see just this point just at the top there, marked with a little stitch at the top, and that was the area of biopsy that was taken and was came back as pretty normal kidney. However, macroscopically, this was far from a normal kidney, as you can see here. The perfusion and the colour as well. So we didn't put that one in.
So the point to stress when you are biopsying or an abnormal kidney, biopsy the abnormal bit, not the 10% that is normal. But suffice to say, we don't actually know what the issue was with this kidney. It on close up, you might appreciate it looked like a cauliflower. There were quite significant depressions within the parenchyma. Yeah.
And of course, there's this difficult anatomy as well. This kidney with 4 arteries, and a single vein as well. Well, yeah.
So we use this picture to demonstrate that this kidney came with a single artery on a patch and other arteries that were not appreciated and advertised as single artery, single vein. And there was a single artery on a patch, but there were 3 other arteries along with the kidney. It's also a very large kidney, so it's about 13 centimeters long, going into a recipient that was about 50 kilos and a BMI of 19, and a fairly small pelvis. And it wasn't, it was going to be a very tough fit to get a single artery, single vein kidney in, but particularly a kidney that turned into 4 arteries. We thought that this was a step too far for this recipient, and we passed the kidney back to Donate Life. Santosh.
I just want to keep reinforcing the fact that we require CT scans, we require imaging. All these things would have been picked up. It's really absurd that we are actually in this so-called second-hand market, and we do not know what the hell we are taking and passing on. And there is a lot of resources and money that could be saved by just getting a simple CT scan.
Yeah, I agree. But we also fall back to the position as well that it's really important to for good retrieval technique and identification of vascular variants in multiple arteries. And occasionally you can, particularly if the arteries are very close together on a patch, you might be able to get away with 1 or 2 anastomosis in multi-artery kidneys. But if you don't have that luxury, then it makes it very difficult on the recipient surgeon, and reconstruction of vessels and arteries of this size and anastomosis onto the side of a main renal artery is pretty fraught as well. So we're compromising to an extent on the recipient for things that could have been avoided in the donation surgery.
So this one came on an aortic patch, unfortunately, with a bit of just gentle manipulation. We see the complete dissection and the patch coming off, and left with a non-usable patch at that stage as well.
So this is an injury presumed to be a dissection in at the time of perfusion in the donor, and it didn't. I mean, you might appreciate that there's not been much work on the kidney to look at the perfusion, but beyond that, it didn't. It just took getting it out of the bag for the whole aortic patch to fall off, and to be able to see that there was significant dissection that then also went down the renal arteries. So good assessment of the kidney and reporting of findings is really important at the donor hospital, at the donor surgery hospital. In states where, as I said, there are multiple surgeons, perhaps going out to retrieve for multiple other hospitals, we're really reliant on your assessment to be able to get a really good indication as to whether or not we're able to go ahead with a transplant. There are multiple resources that are used in the recipient hospital theatres, anaesthetics, in addition to the patients coming all the way through to theatre, that could be averted if we actually had the information from the donor surgery. So yeah, a non-usable kidney, poor aortic patches. We've all seen really terrible aortic patches, but this seemed to be an example of dissection at the time of donor surgery.
Yeah.
Santosh.
Yeah, just trying to be the devil's advocate here. But how many of you actually do the back table first and then only start the ATG and all that stuff on the recipient? Because I find that I have got caught a few times starting the patient and then opening things up and to find that there's a disaster, the kidney is not going to be implanted. And so now my modus operandi is I have a look, I make sure I in fact do most of my back table and then only get the patient in and the ATG and everything starts. Is that what everybody is doing these days, or?
I'll start personally. We don't use ATG. We use basiliximab, which is fairly expensive, about $7,000 a dose. And I would certainly make sure that I was happy that the kidney was going to be used before the patient came into theatre. So from the anaesthetic bay into theatre, I've been caught out once where the patient was put to sleep, and I found an aneurysm, which we'll see on a few further pictures, that I couldn't repair. And that patient was not happy when they woke up. But that's what we do, but that's our induction immunosuppression, a bit different, to ATG. Anybody else have anecdotes about what they do at their particular hospitals in terms of when they get the patient through to theatre? Taina, are you still there?
Yeah, with us, I mean, usually by the time that the patient comes into the room, we've finished the back table anyway. So, I mean, I don't specifically delay the patient being sent just because, I mean, I'm sure you know, Emma, working at Westmead, if you lose the spot, it could be hours before we get another position. So, but yeah, often, I mean, all the surgeons, we know most of the surgeons that retrieve, I guess, and I guess part of it is just trusting the donor surgeon, but obviously if you don't know the donor surgeon, then it can complicate things just depending on how much work they do on the kidney at the donor procedure.
Yeah, that's right. That's correct. I suppose to clarify, we have the patients just outside of theatre in a little anaesthetic bay and have them waiting there until we're happy. We're also pretty short for spots in theatre.
Yeah. It'd be a long time to wait for them to come from the ward.
Yeah, definitely. Like if we know that there might be a problem, then I wouldn't put the patient to sleep if I'm worried that there might be something, but
this was the one that Emma was talking about where found a little aneurysm in the artery. And so we couldn't go ahead with this.
So I realise that we've had discussed whole topics in regards to vascular reconstruction, but this was an aneurysm that was found actually quite fairly close to the hilum and only found and really quite evident when the artery was flushed and the aneurysm was kind of allowed to billow out, but it took up more than 50-60% of the circumference of the other artery at that junction. I just felt it was a bridge too far to try and fix that and not expect problems in that recipient. So some people don't necessarily go this close to the hilum. We tend to go a little bit closer into the, closer to the hilum than I suppose that when I worked at Westmead, we didn't get as close. But certainly the technique of perfusing and pressurizing the vessels to identify vascular problems is very useful before you get the patient through. In this case, actually, this was a patient who went off to sleep. Yeah, was not happy when they woke up and did get basiliximab. So, so now I wait and pressure test the vessels.
So I might just move on a bit, just in the interest of time, just given there's only a couple of minutes left. Obviously, this was a ureteric injury as well. So the question is sort of how we can improve. How can we get better in using and one of the things that we talk about, and Santosh you talked about as well, is just renal imaging, getting those CTs beforehand, getting clear information. It is odd that this is not an area that we do this routinely in, where it's very unlikely that we work in the abdomen without a CT, specifically when we need to look at vascular anatomy and need to look at whether there's abnormalities as well. That's one use. The other thing is, just recipient selection. So understanding who the potential recipient is and what their surgical issues are, and then also their tolerance of complications related to the marginal donors as well. And then the back table issues that we've talked about as well. So adequate training and supervision. And as Emma pointed out before, just a agreed technique for biopsy and a standardization for interpreting those biopsies as well, with regard to future prediction of the quality of the organ and the outcome of the organ as well. And then just wanted to talk a little bit about organ perfusion, but we've kind of run out of time. But as we've talked about in previous ones of this, we see this as enabled to sort of successful transplantation in kidneys that were declined in centres. And in one study in the UK, we looked, there was a 40% able to use 40% of declined kidneys that were salvaged on the perfusion machine. And I know we've talked about this a number of in the last couple of discussions as well, but this is definitely one of the areas of interest and the areas where we can look at using these marginal donors and looking at within the future getting some good risk analysis and calculators to be able to determine which ones are viable and which ones not, and then which recipients we can put those in as well. So yeah, a lot of exciting things to happen in that space, definitely. There's only 2 minutes to go, but if anyone's got some discussion about that or something they'd like to put forward about the role of organ perfusion within these marginal donors and the role within non-utilisation of kidneys. Yeah, open it up to have a bit of discussion about that and just in the last few moments we've had. Go for it, Santosh.
What are the when we look at machine perfusions, the regional normothermic perfusion that is now taking off in Europe and the US and other countries, how is that? Is that better than the normothermic and hypothermic pump perfusions, or especially to sort of prevent or decrease the discard rate? Have you read anything on that, Joel?
Because that's within the DCD population only, isn't it? They're generally looking at the regional perfusion. No, I haven't actually looked too much into that. Sorry, I understand a bit about it, and hence why we're looking into that. But I haven't looked at that specifically in terms of its benefit over hypothermic or normothermic perfusion. Sorry, Santos, I can't answer that. I'm not sure if anyone else has some.
Do you have any data on that, Amma? Are you still online?
Yeah, sorry, I missed the question.
The benefits of normothermic regional perfusion, sorry, so in the donor compared to normothermic machine perfusion excite you. Does it improve? Does the regional perfusion improve or give you a better assessment of quality of the organ in DCD?
From the time I spent it in Edinburgh, they never really looked or assessed the kidney during NRP. You just take it and transplant it, but their DGF rates are pretty low. It's like 20%. It helps and works better than NMP. I think NMP is much better as just a ex situ sort of assessment method. But especially that is at that 1 hour sort of time period we do, it doesn't necessarily improve the function of the kidney, I think. But I think NRP in general is probably a lot more promising.
Yeah. And in terms of regional perfusion, were you saying that you generally don't get a very good look at the kidneys until they're retrieved, until they're actually removed from the donor?
See them at all, because you sort of put the cannulas in like any DCD. You don't do any dissection.
Yeah.
Do the NRP for 2 hours and then cold perfuse and then sort of take it out like a DCD again.
Yeah.
Yeah.
Okay. And then you just transplant it from there. There's no role to actually put it on a ex situ.
You could, like,
machine.
if you like some units just do that routinely anyway, especially if they think there's going to be a prolonged cold time or something like that. But that sort of depends on a lot of things. But the Edinburgh unit, they wouldn't do that, but because they didn't have a machine for that. They spent their money on NRP.
Had to make a choice. Yeah, I suppose in retrieval surgery, I mean, across the world is quite different, and certainly in the US, where there are OPO organisations, are very focused on retrieval and then interventions that will increase the yield of organs. It's very interesting. I mean, they have massive, and particularly the larger centres now have massive dedicated retrieval centres where donors are transferred to the centre to be further worked up and then undergo their procedure, and then organs go on essentially non-ischemic machine perfusion, and they will have multiple organs at any one time, and then, you know, onward selling to transplant units. So, I mean, it's a much different beast in the US, and we certainly wouldn't be, you know, necessarily looking at anything like that in Australia anytime soon. But I think we could do, you know, there's various things that we could do to improve non-utilisation. As we have suggested, and has been mentioned a few times, having some imaging to avoid retrieval in recipients, or particularly marginal recipients where the anatomy is not favourable and the risks accumulating. Having, you know, very mindful technique and good reporting from the donor surgery and donor hospital, and also having those conversations in centres or in states where there are multiple potential donor surgeons and multiple potential recipient units, having good appreciation of the potential surgical and anatomical issues with organs, and discussion between nephrologists and surgeons, even at the time of organ offer or with Donate Life, to better appreciate the potential risks, so we minimise that gap that we may have when organs get to hospitals and are deemed not suitable for that particular recipient, where they may be suitable for a well-selected recipient, acknowledging, you know, the risks. So if there are no, Santosh, we'll let you go. Yeah.
Thank you. Before I thought I'll jump in before people start logging off. I just want to thank everyone for coming today. But more importantly, the next one is on 11th of August. And at 6:30, we will have the annual general body meeting. So I would suggest, I would request everybody, especially all the young transplant surgeons and people who have you know, retired as well, all of them to come and join us for the AGM, and we can plan our journey forward. Yeah, I'll leave the final closing statement to Emma.
Thanks, Santosh. That is the final closing statement. But thank you all for coming. As I said, it's nice to see and hear from many familiar people. And hello to Richard Allen out there. And thank you very much, Joel, for presenting.
Thanks,
presenting
everyone.
that done. Good night.
Thank you. Good night.
Thank you.
Thank you, Joel. See you
Thank
guys.
you.
See you
Bye.
later.
Thanks.